Well, thank you for joining us today. I am Melissa Mitchell with PMD Alliance, and today we're having a conversation around how OFF impacts our care partners. This is a talk around care partners because it is National Family Caregivers Month this month. We've been doing several programs this month featuring care partner topics. They're very important to us. Today is another one that we're doing in partnership with our friends with Amneal. And actually, some of you participated recently in a focus group that we had around this topic. And we're going to be talking a little bit about some of those questions that we asked in that focus group and some of the results that we had from some polls that we took through that. But what we wanted to talk today is from a different perspective. As you hear us talk a lot about OFF, and we know that it's sort of a nebulous concept in some ways, but we always talk about it from the patient's perspective. So we are going to define and talk about what that is, but we really want to focus today on the experience from the care partner's perspective, because honestly, when you are helping your loved one and you're going to doctor's appointments and you're trying to manage their life, it's really focused on them. But we all know that Parkinson's doesn't just impact the person with the actual diagnosis, it impacts everyone, especially the care partners, the ones that's walking alongside them in this journey. In lots of different ways. It impacts emotionally and it impacts physically on your health and well-being. If they're not doing well, then you're often impacted helping them, less time, and even just some other things that we will cover, such as just interactions with your loved one. All of these things impact you, impact your health. And honestly, it is often not a consideration in the treatment plan. And so we want to discuss that a little bit today. And with us today is Dr. Melissa Armstrong, and she is with the University of Florida's Health Mandarin Clinic Research Headquarters for Lewy Body Dementia, which is one of 25 Lewy Body Dementia Association Research Centers of Excellence, another Floridian. Her research interests focus on the lived experience of Parkinson's disease and Lewy body dementia for those both living with the disease, the person diagnosed, but also from the care partner's perspective. So that's what we're going to be focusing on today with Dr. Armstrong. So thanks for joining us.
Well, thank you so much for inviting me.
Awesome. So I want to dive in first. So let's get kind of the basics done and out of the way and go back to that description of what is OFF, because it is very nebulous and it is very varied by different people, but it also has different expressions.
Yeah, so an OFF time is when a person with Parkinson's benefits from medication. So you take that carbidopa, levodopa, or one of the other medications, and the symptoms get better. And then at the end of the dose, those symptoms that got better with medication get worse again. And so OFF symptoms are a little bit different than just Parkinson's symptoms in general, because unfortunately there are some Parkinson's symptoms that just don't get much better with medication. So walking and balance sometimes gets better with medicine and sometimes doesn't. Fatigue, the medicine almost never helps fatigue. And so if a symptom is there all the time, whether you take the medicine or not, then it's not really an OFF symptom. It's just a part of the Parkinson's that our medications aren't very good at treating. But if you take Parkinson medication and the symptom gets better, and it's better for a while, but then at the end of the dose, those symptoms start coming back, that's what we say is an OFF symptom or an OFF period. Now, early in Parkinson's, people often don't have OFF periods because their brain is still making some of the chemical dopamine and the medication is giving them some extra dopamine. And so between what the brain is making naturally and the medication, something is helping all the time. But once you've lived with Parkinson for a while, your brain doesn't make as much of the dopamine. The medicine isn't lasting as long. then at the end of the dose, when those symptoms that got better are now getting worse again, that's what we call an off.
And there can be different ways that that impacts people. So like they can wear off. So we hear that term, wearing off. Can you explain that a little bit?
Yeah, so we say wearing off when as people approach the end of the dose, generally, gradually, those Parkinson symptoms that improved with the medication gradually get worse again. So your tremor got better with the medication, and as you get towards the end of the dose, you start shaking more. Or your stiffness got better with medication, and at the end of the dose, you get stiffer. And usually that's a gradual thing. Sometimes it doesn't get all the way back to its worst because you take your next dose of medication. But in some people, there can be sudden offs where, like, all of a sudden, the medicine's gone, the symptoms are back. And in the research we did, those sudden offs are the ones that are particularly difficult to deal with because you don't know when they're coming, and they're really bad really fast. And then usually we think of off times occurring at the end of the dose, but for some people, off periods can be unpredictable. You know, often you can say, I take my medicine every 4 hours, and at 3.5, I notice some of those symptoms coming back. But it's not always like that for everybody. And if the off period where the sudden symptoms come back is unpredictable, that also can be particularly difficult.
And then there's also those people that can take a medication and it just doesn't kick in, just doesn't ever work. And what do we call that?
So there are kind of multiple scenarios there. So there's one scenario where you take a medication and normally it does help, but then sometimes it doesn't. And that we call like a dose failure, where usually the medicine works, but this time when you took it, nothing happened. That we would call a dose failure. But then if the medicine just doesn't really help, and this can happen to some people with Parkinson's or with some things in the Parkinson family, that doesn't really have a name, then we just say that people are unresponsive to medication.
And then I've also heard off being an issue in the morning. So someone wakes up and they're off, and that can be a real struggle too.
Yeah, so that's a little bit different than what I discussed, but absolutely part of it. So usually first thing in the morning, you know, people have gone most of the night without taking medication. So first thing in the morning, they are off because it's been so long, the medicine isn't in their system anymore. So then they take their first dose to get on. So I explained offs as being at the end of the dose, but you're absolutely right. Morning, most people wake up off because they haven't had their medicine since the night before. And there are some tricks for that people can talk about with their doctors. So a lot of times people with Parkinson's are waking up overnight. And so one thing I sometimes talk about when the mornings are really a problem, we'll talk about having a pill in a Dixie cup at the sink. And when they wake up naturally, I don't want any pill alarms overnight. Like if you're sleeping, I want you to sleep. But if you wake up, I'll say, you know, if you wake up naturally to pee between 2 and 6 a.m., I want you to take one pill when you wake up naturally. And the idea is that can kind of prime the pump. So when they get up first thing in the morning, there's a little bit already in their system. There are a few different tricks we can use for that. But that helps that morning off time before you get going with your medication for the day.
And we had a question around why a dose failure actually happens. Like what is going, why is it sometimes the medication works and sometimes it doesn't?
Yeah, so I'd say for most people, most of the time, the doses are fairly reliable, but there's no doubt that there are some people, especially when they've had Parkinson's for a while, who can have these dose failures. And we don't know exactly why that might happen. There are some reasons we do know. So sometimes the pill doesn't dissolve as well or absorb as well. We know that the regular carbidopa levodopa extended release, not the brand name Rotari, but the the one we've had for a while, it doesn't dissolve very well or very reliably, and then we have some trouble absorbing it. So it doesn't always kick in kind of the way we expect. Or if someone's really constipated and then they're all backed up, then there's actually less place for the medicine to be absorbed. So we know it can be a problem with the pill dissolving. It can be a problem with the gut absorbing it, but there may be other reasons too, and we don't know always why they happen.
And someone asked about the overnight dose, and you said, don't wake up if you're sleeping. So any other like tips of how people can maybe help?
Yeah, so I have a few different tricks I use, and obviously you would want to talk about these with your doctor. So one trick we use is that controlled release or extended release carbidopa levodopa. We'll use at bedtime. It's not quite as reliable as the regular carbidopa levodopa, but at bedtime, we're not so worried about exactly when it kicks in. We want to give a little overnight coverage. The second trick I use is using a dose in the middle of the night and not setting the alarm for it, but taking it when you are waking up naturally. And then there are some other tricks. So if you chew, even though the carbidopa levodopa isn't designed to be chewed, if you chew it or crush it, it'll kick in a little faster. So sometimes I'll have people chew or crush their first dose of the day to get it to kick in a little bit faster. And carbonated beverages can actually help it kick in a little faster too. So we have a few tricks for giving some medicine overnight, and then a couple tricks for getting that first dose of the day to kick in a little bit faster. You can also, when you wake for the day, take your first dose and then kind of hang out in bed for 30 minutes to give it some time to kick in before you get up for the day.
Take it, hit snooze, and go back to sleep for a little bit.
Exactly.
So I want to talk a little bit about non-motor expressions of off. I know that was a concern someone had raised earlier, because I think that'll segue into some of these things that we had asked these care partners and kind of wanted to discuss today. So could you talk a little bit? I know you mentioned a few of the motor symptoms. Could you highlight some of the non-motor symptoms?
Absolutely. So when we think about wearing off, kind of the classic thing we think about is those motor symptoms. So the tremor comes back, the stiffness comes back, the slowness comes back. If someone has a gait problem that responds to medication, the gait changes at the end of the dose. But we know that some of the non-motor features of Parkinson's disease can also fluctuate with a dose. And so when you have one of these features, it's always worth thinking about, well, is it there all the time? In which case it's just, a symptom of the Parkinson, or does it go up and down with the Parkinson medication? So cognitive impairment, memory and thinking changes, for some people, they're just there all the time. They don't change with the carbidopa levodopa or the other Parkinson medicine, they're just constant. But sometimes people notice that they're worse at the end of a dose. And so for them, they have a non-motor off. Anxiety is another really common example. We know that over half of people with Parkinson's will have anxiety. And a lot of times it's just anxiety that's there all the time, or, good times and bad times, but not necessarily tied to a dose. But for some people, the anxiety is clearly worse at the end of the dose and clearly gets better when they take their carbidopa levodopa. So for them, anxiety can be an off symptom. And when we did interviews of people with Parkinson's and with care partners, we found that there's a whole host of non-motor symptoms that for some people get worse at the end of a dose. So fatigue, for some people it's there all the time, but for some people it's clearly worse at the end of the dose. Some people notice that urinary problem, so having to rush to the bathroom or having a hard time controlling the urine. For some people that can just be there all the time, but some people found that it was really worse at the end of a dose. And so a lot of these non-motor features that people can have, memory and thinking changes, anxiety, fatigue, urinary symptoms, for a lot of people, it won't change with the carbidopa-levodopa or the other Parkinson drugs, but for some people, they can really, that's their clue that they're at the end of the dose and they're due for their next dose.
We've had 3 people ask specifically around shortness of breath. Is that something that could be expressed as an off symptom?
So, excuse me, so maybe. So that's a little bit trickier. In general, we don't think of a lot of shortness of breath happening with Parkinson's. And so when someone tells me they have shortness of breath, I never blame the Parkinson's to start. I always say, I think you need to get checked out, because we don't think of it as a super common Parkinson's symptom. And so I really want to make sure that something else isn't happening. Sometimes if it happens at peak dose, so if that shortness of breath happens about an hour after a dose, there's something called a respiratory dyskinesia. So just like you can, have movements all over the dyskinesias when you're at a peak dose, sometimes those dyskinesias can affect the respiratory muscles, the breathing muscles. So uncommon, but I've had a couple people with respiratory dyskinesias that are at that peak dose. And then if it always happens at the end of a dose, so if someone's not short of breath any other time, but it's always at the end of the dose, I would say possible. And then what we would do, I would kind of take 2 approaches. I'd say, well, let's make sure nothing else is happening, because this isn't something I want to just blame on the Parkinson's. But at the same time, let's try treating the off period and see if that helps at all.
And there's other things that are tied to autonomic dysfunction that can happen with OFF2, correct? Like maybe temperature dysregulation or anything like that that people might see.
Yeah, so I'd say most of the time I feel like that autonomic dysfunction, so the blood pressure dropping when you first stand up, being more sensitive to heat and cold, things like that. I would say more often, I think of that being a constant thing rather than something we would see just purely at the end of the dose. Parkinson's is so different from person to person that I wouldn't say that couldn't be possible, but I would say that's not one of the more common ones. But everybody's different. And so I think that's one of the challenges of Parkinson's, but also, something we always need to be open to. Well, maybe I haven't seen that, but it's so different in different people that we have to keep in mind that it could be a possibility.
So I think this is a good segue into one of the topics that we discussed in the focus group, and that is the perception of off episodes from the person with Parkinson's versus the care partners. And the actual question that we asked our care partner was, I feel my loved one and I have similar insight into their off state, which is an important thing to kind of be on the same page. 21% reported rarely do they feel that they have similar insights, and 21% said they never have similar insights, which is pretty significant. In fact, one of the comments made in that focus group was, my person with Parkinson's lack of awareness is a significant symptom that permeates all of our interactions about his medication and symptom management. I'm sure probably impacts communication with the physician. And I know this is something that, you surfaced sort of in your work. In fact, I think you even had some statistics that you referenced. 87% of patients and 74% of care partners said they understood what wearing off meant, but 30% of patients and only 17% of care partners were able to correctly identify it. So I think that's a key thing, because we also did a survey that found that most care partners felt confident in their knowledge of off, but 71% were incorrectly identifying off. So I think having these conversations regularly, because it is such a, like I said earlier, like a nebulous concept, is important. So I would love if you could talk about this, because it does have a huge impact on quality of life.
Yeah, so I think there's a lot to unpack there. So first, there's just the fact that, the off terminology is kind of nebulous or confusing. And I definitely have people who tell me they're off, but they're symptoms that just our medicine has never made better. And so from a technical standpoint, that's not so much an off, because an off requires that the medicine help with that symptom, but they're having symptoms that do not respond to medication. And those are super frustrating. It's just a little bit of a different thing. But then one of the other points that you just made is that care partners and people with Parkinson's can have different views, different experiences, different appreciation for what's happening. And in the interviews that we did, so we did a study several years ago now where we interviewed people living with Parkinson's about their off time, and we interviewed their care partners about the off time. So these were dyads, these were couples, not necessarily married, but people with Parkinson and their care partners about off. And when we compared their responses, we didn't go into this saying, well, let's compare and see what they tell us, but we said, well, let's look, where were things similar and where were they different? They were different in both directions. So there were some times where the care partner really noticed a lot of stuff and reported, oh, how much the wearing off affected their life. And the person with Parkinson's, didn't really mention it or took it in stride. And then where there were times where the care partner seemed to not be too bothered and take it in stride, and the person with Parkinson's reported really being affected or reported a lot of wearing off symptoms. And I think there are a lot of aspects of that. So some of that is going to be personality. Some of that is going to be how we cope. And some of it is going to be that awareness of, are the people living with Parkinson's as aware of some of these symptoms as that care partner and that outside observer? So I think it's a complicated thing with a lot of different aspects to it.
Yeah. And, I'd love to know, like, what do you tell your patients or your couples when they come in terms of coming in together and sharing the experiences? How do you use that in your practice?
Oh, it's so important to have both. So I always encourage people to bring someone with them to the appointment, because I really want both of those perspectives. I usually start by talking to the person with Parkinson's, the person who's living in that body with Parkinson's, and asking them about what they're noticing, what they're experiencing, what's affecting their quality of life. But then I always pivot after I get all that information. I pivot and I talk to that care partner. What do they see? Because sometimes what you experience living with it and what you observe are two different things. And I really need both of those pieces of information. And so I think if we're going to get a pretty full picture, we need kind of both sides of the story. And it's not that one is right and one is wrong. Those are, complementary pieces of information.
Absolutely. And I love one of the comments from Carol. She said, I can almost feel his off time. All I have to do is look at his face. But we know each other very well, been together since we were 12 and we're now 76. So I guess you probably do, feel him. You know what they say, you start looking like each other. Maybe you guys look like each other at this point. I'm just kidding. But, I think that is an important perspective of being able to visibly see things. We don't see ourselves unless we're looking in the mirror. So having someone say, I can actually see this happening.
Yeah, and I think that's absolutely right. So, sometimes it's really obvious. So sometimes, if it's a resting tremor, everybody knows when it comes back. But sometimes it's that more subtle stuff where, the expression changes and you're like, oh, it's time. Or the gait slows. And sometimes those are things that care partner really notices more than the person living with it.
Yeah. And you mentioned that there was a question, and I'm trying to scroll up to find it. I think it was around like somebody just kind of staring off and kind of zoned out. Is that something somebody would obviously recognize? Is that a typical or could be an off response?
That's a great question. So it's possible, but it could also be something else. So if that kind of Decreased responsiveness, lack of awareness always happens. It's pretty consistent at the end of the dose. It could be a wearing off. But there's also something in Parkinson's disease called cognitive fluctuations. And those are a little bit different than kind of the motor fluctuations or the wearing off. Cognitive fluctuations are when at some moment people are interactive, they kind of seem like their old selves, they're talking, they're interacting, and other moments they're like confused and zoned out, they're not alert. Sometimes people call them nobody's home episodes. Hello, anybody home? And those cognitive fluctuations, they get more common when people have longer time with Parkinson's, and especially when the Parkinson's has started to affect the memory and thinking, those cognitive fluctuations can happen, and those don't necessarily time out to medication timing. And so if we're ever trying to figure that out, what I do is I have people keep a diary. And we only do this for a few days. Once someone brought me a stack where they had kept a diary for a month, and I cannot take in that much information. But like we'll do it for like 3 days, and we'll have people write out, well, when did you take your medication? When did you eat? And then what are like the 1 to 3 symptoms we want to track? And then I have people check off or write down the time. When did those symptoms happen? And that helps us figure out, is this a peak dose symptom? It always happens about an hour after medication. Is this a low dose symptom and off? It consistently happened, at the end of the dose before the next dose. Or is this kind of unrelated? A really good example of often unrelated is freezing of gait. Occasionally freezing of gait, where your feet kind of get stuck to the floor and you can't move. Occasionally that will be an off symptom. It consistently happens at the end of the dose, but often it seems completely unrelated to medication timing. And so if it always happens at the end of the dose, then adjusting the medication regimen to try to get rid of the off time can help. But if it happens at any time unrelated to medicine timing, then that can be really hard to treat.
And those things that are hard to treat and can still be, fluctuating is often the thing that kind of impacts people, the care partners and the family members and plans. So we did another question, and we asked them, whether the off episodes made them compromise or change plans. And 20% said often, and 53% said sometimes. And I think that's pretty impactful, because we understand that, if you're not going out for, a variety of reasons, maybe it's the cognitive fluctuations, maybe it's agitation, maybe it's just, physically not feeling well and it's taking a while for meds to kick in, then you're isolating. And we know how that impacts the person with the disease. But can you talk a little bit about those impacts on care partners and what you've found in your work?
Absolutely. Well, whether these symptoms are predictable or unpredictable, they both affect kind of the ability to plan, to go out, to socialize. And so people, even with kind of the predictable offs, where we know at 3.5 hours, the medicine's going to wear off and there's going to be downtime for 30 minutes, before the next dose kicks in, even when it's predictable, care partners talk about how hard that is, because they have to plan their entire life around that schedule. So it's predictable, but it's very constraining. So they know that they have this little window in the morning to get things done, but they have to be home by 11:30 because it's all going to go downhill at 11:30. And they have a little window in early afternoon, where they can run errands because they want to make sure that they're home before the low time in the afternoon. So even when off time is predictable, that really is very hard, not only on the person living with the Parkinson's, but the care partner, because everything you do has to be planned according to that schedule. And for care partners, it's anything you do together, but many of them talked about how anything they do alone, they also feel like they have to plan around that schedule so they know they'll be home at the downtime. And then it's even worse if people have unpredictable offs, because then you're live in constant fear of, could this happen when we're out? And that really kind of, or could this happen to them at home while I'm out? And so those unpredictable offs make a hard situation even worse.
And stressful, just very stressful, regardless whether it's predictable or unpredictable.
Yes.
It's both very stressful.
So when we talked to care partners about this, they talked about how the off periods caused a lot of fear. They were always afraid that their loved one was going to have an off when they were together or when they were apart, that caused a lot of stress, frustration. And so it really does, affect not only the person living with the Parkinson's, but also that care partner.
Yeah, someone wrote intolerance of uncertainty. Yes, that's a tough one. And there's not an easy answer to that. I mean, I'm sure, because it's all about timing, and you can't predict whether someone's going to respond, and some days they do and sometimes they don't. And that's just hard, I would imagine, as a treating physician to even help them walk through that.
Yeah, I mean, so we have some like tricks. They're just practical things. And so they make it like a little bit better, but they don't really solve the problem. They just help give people more support. So, I always say you always should have extra medication with you. So extra medicine in a purse or extra medicine in the glove box. There should always be that extra medicine with you, so you have that kind of backup if you need it. For people whose gait is really affected, their walking is really affected, I'll tell people to buy a transport wheelchair. You can get them on Amazon. You can get them used at some medical supply, just the cheap one. Don't use your Medicare benefit. You only get one wheelchair. You don't want to use your Medicare benefit for a transport wheelchair. You want to use that just in case you need a good one down the road. But, get just the easy, light one and keep it in your trunk. I don't want people to use a wheelchair. There's truth to use it or lose it. But it's so much more convenient that if you're at a restaurant and all of a sudden someone's off and can't really walk back to the car, you can just go, open your trunk, grab that light transport wheelchair, get it to the restaurant and get them out. So, if urination's a problem, I tell people, keep a change of old clothes in the trunk in a bag. So there's always that backup plan if you need it. So we do a lot of backup planning, and that's not really satisfying because it doesn't get rid of that fear of when is it going to happen. It doesn't change the need to schedule around it, but we do try to get some backup plans in place so that people still can go out even with these limitations.
Well, and I want to go to that next poll question that we asked, because it talks about this specifically. And so we asked them, my loved one's off episodes have made me feel discouraged and frustrated. 53% said often. So, I mean, you've surfaced a lot of things, just that feeling trapped, that stress of unpredictability, that for some, a loss of connection, personal identity is kind of stripped away, that loss of socialization. All of those things, those are psychosocial aspects of life tied to these physical issues. And that's both the person with and the care partner.
Yeah, and some of the interviews we did talk to about that struggle of knowing how best to handle it. So some of the caregivers we interviewed talked about, well, I want to remind my loved one with Parkinson's, like, did you take it? Did you take it? But at the same time, I want to respect their independence. But that's a really tough road. You want them to do it on their own. You want them to be independent if they can be, but you also want to try to avoid the off time. So navigating that narrow road of supporting but not nagging, that's such a challenge. And that's not specific to Parkinson's, but it definitely comes out in Parkinson's too.
One of the comments during the focus group was, this causes a lot of fights and added stress on me as the care partner. We just had a comment from Anna Maria, life is uncertain for everybody. We have the illusion that we can plan life. For persons with PD and loved ones, that uncertainty is more obvious. So how do we manage expectations is the question.
So it's tough. So there are so many different aspects to that. One aspect is for, people living with Parkinson's and their care partners is being pragmatic. So really planning things for the consistently good time. So if mornings are better, really planning things for the morning. And when I say planning things, I don't just mean, social outings or going to the grocery store, but I also mean like those important conversations. So in our interviews, one of the caregivers talked about how she just realized that if they really needed a conversation, an important one, talking about, a family issue or moving or whatnot, she had to do that at the beginning of the dose. So I think part of it is being practical, knowing, okay, this is the reliably good time when our family visits. Like, let's make sure that we're making good use of the consistently good time. When we have that important conversation, let's do it in the consistently good time. So there is a pragmatic element to all of this for planning and for backup planning, but it's tough, and then if you are worried, like when family come to visit, we do talk about, well, talk about what the person with Parkinson's can do now or can't do, or, prepare people for that kind of unexpected element. So the kids know that, sometimes it's a bad time and we can't predict when that happens. So, kind of forewarning people that this is part of it now.
Carol's comment, so difficult to be thinking for two, and that's true. And, that kind of leads into the topic. And I know you had that article that I had referenced for a lot of the discussion was around, and you didn't write specifically to this, but it came up in our focus group, and that is around that mutuality in relationships and how it often impacts that. And so basically what that means is that reciprocity in your relationship, like, your loved one may have been, very, affectionate and like to talk and would engage in conversation, and now is less interactive and may not interact at all, maybe because of apathy or lots of different things. And, that right there is a very difficult experience for care partners, maybe more than dealing with any of the physical aspects of the motor symptoms, but just not having that interaction before. In fact, one person said their conversations are now basically non-existent, and because they don't communicate, it makes them wonder if they even enjoy activities that they do together, and that this person just feels alone even though they're not alone. There's loved ones there, but they feel alone. So I would love if you could talk a little bit about what might be going on and just that whole issue.
Yeah, I think Parkinson's affects relationships in so many different ways. So there's, the physical part of it, the person with Parkinson's becoming more reliant physically. There's the fact that Parkinson's affects memory and thinking. There's the apathy, the loss of interest, the depression, the anxiety. And so that really affects all aspects of life. And, I think one important thing to note is that it's okay and it's right to grieve these things. So Parkinson's isn't a loss that just happens once and then you're like, you get over it. It's a series of losses. So you grieve when you get the diagnosis, but then you might grieve when someone can't go out on their own anymore. You grieve the retirement that you planned, but you never got to live. You grieve the loss of this marriage relationship that used to be much more even, and now one person is giving a lot more than the other. And so I think it's really important to acknowledge that, like, these are hard and sad, and these are things that aren't the way they were supposed to be and aren't the way we want them to be. And there's no easy answer to that. And so there is a grieving process with that, the mourning what we had hoped for that now isn't going to happen. So I think it's really important to give space for that. And then one other thing I talk about is trying to create spaces for that relationship. So when you are a caregiver, your relationship with the person with Parkinson's really changes. And this is true if you're a spouse, this is true if you're a child, the relationship has changed. And you can't totally get rid of that. Like, they need you to help them. But, and this is going to look different for everybody because it's going to depend on you and your relationships. But, you know, if you have the resources to hire someone to give some help, so you're not always in that caregiving role. So like if you're a child caregiver, hiring someone to help your parent bathe or something like that. But if you're a spouse caregiver thinking, okay, I spend all this time caregiving, but could we create a date night where we're more like a couple and less like a caregiver and care recipient? Mm-hmm. So you still, so much of your time is still spent caregiving, but you create these islands of this night, this is a date night. We're gonna put out the candles. I'm gonna order in a catered dinner. You know, we're gonna look through an old photo album and we're gonna have to try to have 2 hours where we're more like husband and wife and less like caregiver and care recipient. Mm-hmm. And it doesn't get rid of all those hard times you have all day, but trying to create these moments that are a little bit more like the way things used to be.
And I'm so glad you brought that up, because so many people do get wrapped up in the tasks associated with caring for somebody and helping them that they lose that identity of that relationship, whether it's spousal, partner, child, whatever the case may be. It kind of gets lost. And that's where that loss you were talking about can really hit. And you described ambiguous loss, because it really is a loss that there's not one defined thing. It's many little things every single day or over a period of time that keeps happening. So, you know, that's maybe harder to grieve, and it's so important to find those things where you can continue to connect. And I love, someone was saying, you know, we try to find humor, you know, that we do lunches because they're easier than dinner. Maybe that's the better time of the day. And that's a key thing too, right? What works for you? Maybe yes. It's not the same time that we're suggesting, it's something else.
Absolutely. So, you know, none of these things we talk about are going to be perfect for everyone. And there is trial and error, and there's also changes over time. So, you know, lunches work now, and then the disease changes, and then we've got to readjust. So, you know, nothing that I've said is like some magic, and it may or may not work for you, but we do, in my clinic, we do a lot of brainstorming. So like, what is the issue you have? My medicine may or may not fix it. Now, if it's an off time, my medicine might help with it if we could get rid of the off. But honestly, a lot of the things that are the big struggles, my medicines aren't going to fix. So let's brainstorm ways that we can not fix it, but work around it.
Yeah. So, you know, as we kind of start towards the end of the conversation today, one of the other poll questions that we asked was whether care partners have discussed the impact of their loved ones off on their lives as the care partner with the treating physician, and 46% said never. And that's, you know, I know it doesn't seem like a typical conversation maybe to have, because you're not the reason that you're at the physician's, you know, appointment, but because it isn't just something that affects, you know, the person that's diagnosed, it does affect the care partner. I do think that that's probably a very important conversation to have, and it might actually lend some insight for the treating physician to really know beyond just, you know, when is it, you know, wearing off, what time, and how's that fluctuating, but how's it actually impacting the lives. Might tell you how, because sometimes it's, and I'm jumping around a little bit, but it's sort of hard to articulate the variances of off and really what it means for somebody unless you ask them, well, what is it doing to the life? What's it doing to your life, to your emotions, to your relationship? So can you talk a little bit about, that and how you bring that conversation into your practice?
Yeah, so it's tricky. So, we're kind of taught in medicine, particularly Western medicine, that it's about the patient. But I think, in Parkinson's, while there's one person physically living with the disease, it really affects, that whole environment, and especially the main care partner. And we can't, even if we say, hey, our job is to focus on the patient, the person with the disease, you can't do that well without also, taking care of that support structure. And this is what part of why it's so important for caregivers, care partners, to take care of themselves. It's for you. You are important. And so I want you to take care of yourself for you. But it's not selfish. We know that care partners and caregivers who take care of themselves and get breaks, they're better care partners and caregivers. And so that has direct benefit too to the person living with Parkinson's. And so I do like those practical examples because it helps me figure out, maybe as a care partner, you have had to take over the driving because the person with Parkinson's can't drive when it wears off. Some of the people in our interviews talked about how they had to change their jobs because the person with Parkinson's, couldn't be home alone if they were off, or maybe they had an off that made the spouse working late for work. And so, these examples can be helpful in saying, yes, we need to treat the off time. It's not a little deal, it's a big deal. Let's see if we can diminish or get rid of these off periods. But it's also important for us figuring out, well, how do we help you? Are there ways we can help with work or with driving? Should we get our social worker, our case manager involved? And so I think those details are important. And I think when we treat Parkinson's, for me at least, it's important to treat everybody in that immediate environment. Often one issue affects more than one person. Earlier we were talking about sleep. If the person with Parkinson's isn't sleeping, that's not good for them, and it's not good for the care partner. If we've got these off periods that make it hard to walk and create this, regimented schedule, that's hard on the person with Parkinson's and on the care partner. And so those details, I think, really help the medical team say, this is something we should be trying to do something about.
Yeah, absolutely. You're taking a systems approach for sure. And, Teresa just brought up a really good point. And I'm sure there's other care partners that probably feel the same. But she said, when I was told I had to take care of myself, I thought, oh, great. Another thing I have to be responsible for. And that has got a very similar ring to it that, something that we've talked about at PMD Alliance is that, we try to avoid telling people that they need to self-care because when? That's one more thing that you're asking me to do. And, I would love to, but in reality, that's not going to happen. So, when we tell people, we need to address the needs of the care partner, that we need to try to help reduce some of their strain, if they need to take care of themselves, how can we do that practically without actually adding burden to their lives and one more task for them to do?
Well, I don't think there's any easy answer there. There's no quick fix. We can't snap and make it so. I do encourage people, and it can take some time to figure it out, but my goal would be for caregivers to have, a half day a week, more if possible, but a half a day a week where they're not in that caregiving role. Kind of at a minimum. And ideally, not all of that time would be spent grocery shopping, getting the oil changed. It really is important to do some of those other things, like getting your nails done or going to a movie or having coffee with a friend. And so we do use our social worker and case manager to try to help figure this out. There are different options depending on kind of where in their Parkinson's the person living with Parkinson's might be. So for people who are more severely affected, especially memory and thinking, there are adult day programs that, do art and games and, get people involved. And some of our care partners will use that 1 to 2 days a week. Sometimes a child can come over an evening or a half day, or a friend from church will come sit. Sometimes it's hired caregiving. And so there's no doubt that like setting that up absolutely takes some work. And so I don't think there's a no work way to get help, but I think it's really valuable if it can work. And so while there is some upfront effort, with friends or family or a caseworker, sometimes it's worth it if you can find a situation in which you're comfortable. Because if you get that time away and you're just stressed and freaked out about the whole time about what's going to happen, that's not really a good break. But if you can find a support network to let you get away, I really do think it's valuable.
Absolutely. And, if you are not lucky enough to be at a center like University of Florida, Norman Fixel Center, where they have everything under one roof, there's still resources out there. If you've not met with a social worker and talked about what your particular situation is, because it's unique to each individual, everyone's resources is different. What's available in their community is different. You may not have family that lives nearby that can easily be there. You may not have the financial means to be able to just bring in a bunch of care. So what is feasible? So, talking with a social worker can help you just walk through some of those things. Because we know there's not an easy answer. And we know for some people, they're saying the advanced, in the advanced stages, they're getting out is like next to impossible. So what can you do? Maybe it's giving yourself some slack, and just lowering your expectations in general for what you can accomplish in a day. But beyond that, there may be some help that you haven't even thought of, and somebody might be able to direct you to that or problem solve with you. So I do highly encourage that. And, we've had a couple people put in some ideas, like Cecily said, when her husband goes to bed, she goes for a walk. And, this person says that whether her husband watches football, they read their book, they're in a book club. So that's a great way to connect and do something outside of just, being the care partner and everything. So Zoom, a lot of people get on Zoom, do their Zoom worship time, hobbies on, thank God for Zoom. Like, even though it's not any replacement for human interaction, it has really opened up the doors to be able to get on with other care partners and talk and do hobbies and different things like that. Very beneficial. And then I think there was one other question. I want to make sure I don't miss any. Oh, and I love this other comment from Ashley, and she talks about just how they approach everything as a we and an us, as opposed to a him or an I. And so that we ask for help, we stop to breathe, and sometimes they just are together. They just be together and not do anything, which is kind of a nice thing, actually. So any last comments? And I do want to make a comment that something that came up, and I just would love to get your input on this, is from the focus group, they talked about developing a new language around OFF, something a little more accessible. Within the Parkinson's community, we're challenged in understanding OFF. So if we're using that language and we're not dealing with people outside of that, and we talk about OFF and we get these blank stares from people, what can we do to help raise awareness just when we're out interacting with people, so that they understand the experience of people that are experiencing this fluctuation?
Yeah, I think it's another thing for which there's no easy answer. Sometimes if you use more accessible language, like this is his downtime, he has downtime every day, at the end of a dose, rather than OFF. Most people understand that this is a downtime or a low time. So using some of those more accessible words, we use on to mean the medicine is having a good effect, and OFF to mean that beneficial effect is gone. A lot of people will use the analogy of a roller coaster where, you know, he has times where he's at his peak and then time where he's at his low. This is a low time. You know, so those ups and downs, goods and bads, some of that has more meaning to people who aren't in the Parkinson's world than the ons and the offs. I think the on and the off has, excuse me, stayed in kind of Parkinson vocabulary because it has that added sense of, well, we all have good times and bad times. You know, whether or not we have Parkinson's, we have good times and bad times. People with Parkinson's definitely have good times and bad times that don't relate to where they are in their medicine cycle. The on and the off in kind of the Parkinson's world is really indicating that this is something specific to where they are in their medication cycle. But, you know, to the broader community, explaining it as a low or a downtime might have more meaning.
That's helpful. Thank you. Well, I feel like this has been a really helpful conversation, just kind of discussing that experience from the care partner's perspective. And I know we've had a lot of comments, a lot of questions we couldn't even get to. There was just so many of them. I love that interaction. And so I just want to thank you so much for giving your time today and letting us touch on this. I think we could continue this conversation over and over because I feel like we don't get to talk enough about this experience for care partners. So I don't know if you have any last parting words that you want to share with our care partners.
No, I just want to thank you. You know, some of you may live with people who don't say thank you. And I want to thank you for all the work that you do and the support that you give and the caregiving that you do that may be recognized, but you know, a lot of what you probably do isn't recognized by the person with Parkinson's or by your family or by your friends. And so I just want to thank you. It is a hard job to be a care partner, even if it's for someone that you really love and have been with for so many years. It is a hard road. And I want to thank you for all that you do.
Absolutely. And, you know, this month is all about celebrating all of the hard work that our care partners do. So we do thank you. And speaking of thank you, we have a tradition at PMD Alliance, and I believe this is actually the first time we've had Dr. Armstrong on our live stream. So first of all, thank you for, you know, being a first-time participant in our NeuroLife Online. We've had other speakers from UF, but we're very thankful that you joined us today. And we have a tradition at PMD Alliance. So everybody, you can see on the gallery view, if you have your cameras on, let's give Dr. Armstrong the wave of gratitude. And it's just our way of thanking you for your time and your expertise and your obvious compassion. So thank you, Dr. Armstrong.
Thank you.
And thanks everyone for joining us and for all of your comments. I know there's a couple of questions on there. We do have regular support programs or online communities that are like a support group for care partners. So if you go to our website under programs, you can find those. They meet regularly, like monthly with Eden. Eden was on her earlier. I think she may have popped off. She is also a clinical social worker, and we have that as an opportunity for you to connect with one another. That connection is so important. So we'd love you to take that opportunity. And I want to thank Neil for allowing us to have this conversation. And for those of you who participated in that focus group, gave us some of this information to kind of weave in and include into this conversation. Your voice is so important, your experiences and your perspectives. So thank you for that. And I hope the rest of your day is wonderful. Thank you.